All right, so hello again. My name is Mark Driscoll. I am the program manager for the PHP program with the Ohio chapter of the AAP. I'll just kind of start us off today, and then we'll get started into the main portion of today's presentation. We can go to the next slide, I think. So there's our title there. And then okay. So yeah, I think mostly I'm ready to go. So I'll go ahead and introduce our speaker today. Today we have with us Dr. John Dubey. He is a professor and chair of the Department of Pediatrics at Wright State University in the Boonshoff School of Medicine and vice president for academic affairs and community health at Dayton Children's Hospital in Dayton, Ohio. He has a clinical practice in developmental behavioral pediatrics. He's a graduate of the Ohio State University College of Medicine, and he completed his pediatric residency at Baylor College of Medicine and a fellowship in developmental behavioral pediatrics at Boston University School of Medicine. He's a past president of the Ohio chapter of the AAP and the Society for Developmental Behavioral Pediatrics. So without further ado, Dr. John Dubey.
Great. Thank you so much. It's a real pleasure to be with all of you this afternoon. We're going to spend some time talking about anxiety in the tween-age child. And really what that means is that we're going to discuss the prevalence and symptoms and causes and treatment of anxiety in that 9 to 12-year-old age group while sharing resources to support the children and their families. So by the end of this next hour, we should be able to identify common presentations of anxiety in preteen children, talk a bit about the workup of anxiety in preteen children, and list a number of treatment approaches for anxiety in preteen children. So a little bit of background to get us started. Anxiety is possibly the most common mental health problem that we see in pediatrics and is probably the most undertreated. Oftentimes, the time from diagnosis to treatment is measured in decades, meaning that we may really miss it during the pediatric years, and it may not be really fully identified until adulthood. It tends to be chronic, though it can have a waxing and waning course. And I often share with families that it not only does it run in families and have somewhat of a genetic basis, but it also can be contagious, meaning that it's easy for one person's anxiety to trigger anxiety in other members of the family and becomes an escalating, snowballing kind of effect. And anxiety can be very general or it can be very specific. We're going to talk more about general anxiety today than to say, for example, specific phobias, which there can be an interminable list of. And it's important for us to also remember that it's often mixed with depression, although I think in the age group that we're talking about here, it's more common to see anxiety. And as you approach the older age of adolescence, you're more likely to see anxiety with depression or even depression more commonly than anxiety. So I want to just make a point about the fact that it's important to think about this in terms of promoting racial and ethnic equity in psychosocial treatment outcomes for children with anxiety and depression. In this paper that was published in 2022, it highlights the fact that those who are in underrepresented groups have higher risk of developing anxiety, may have a higher burden from the disorder, and will be less likely to receive adequate mental health services. And their access can be affected by a number of different factors, including physical location, language, income, and financing. And oftentimes, families find themselves being required to fit into the demands of the care setting as opposed to the services being available at times that are convenient for them. So there may be sessions that occur during the week in work hours and school hours. And it's important that we consider the fact that adaptations need to be made in order for there to be a broader impact and for there to be personalization of goals. I want to highlight some data from the youth behavior survey that is done regularly here in Ohio. and just highlight for you the fact that this is the percentage of middle school students who most of the time are always felt that they were treated badly or unfairly because of their race or ethnicity. And you can see that those numbers are significant. It's interesting to see that the group that feels like they are most often treated badly are the Hispanic and Latino populations that in these students who responded to this survey here in Ohio in 2021. So how can we get a better sense about the global prevalence of depressive and anxiety symptoms in children and adolescents, and what impact has the COVID-19 pandemic had? This study that was published in 2021 did a meta-analysis of 29 studies that included 80,000 youth globally across the world, and found concerns about depression in about a quarter and about anxiety in about 20%. Now, this was all the way up through adolescence, not just those 9 to 12-year-olds, but it was felt that these numbers really doubled compared with pre-pandemic estimates. And in another study that tried to look at the changes in depression and anxiety, again, among children and adolescents from before to during the pandemic. So the last one was really a cross-sectional study. This is a longitudinal study that looked at over 40,000 kids across 12 different countries. And interestingly, what was seen was more an increase in depression symptoms during the pandemic, and it's particularly among females and those who were from relatively higher income backgrounds. Anxiety symptoms seemed to increase slightly during the pandemic, although there was some evidence of a small increase in anxiety symptoms for children and adolescents, again, from relatively higher income backgrounds. And so that was done and published in 2023. What they showed from this analysis was that there was higher rates of social isolation and quarantine orders. We all know that our own lives were affected that way, and that was associated with a fourfold increased risk in stress-related symptoms among children. And a lot of that led to a variety of different changes in people's behavior, including more screen time, closures and disruptions of school, cancellation of extracurricular activities, more loneliness, less physical activity, and lack of school-based mental health services being available. And then, of course, there was also potential changes that occurred within the family system itself, with increases in parental depression and anxiety symptoms, as well as increases in family violence, job loss, and alcohol consumption that all could lead to elevated stress levels across the entire family and affecting the children as well. And we know that the burden of early mental illness in the long term has been well established. It can lead to impaired cognition and impaired academic performance, quality of life, interpersonal functioning, employment, and physical health in the long term. We know that there's a risk for later psychopathology if you've had early mental illness. You're 13 times more likely to meet diagnostic criteria for generalized anxiety disorder in adulthood, and 20 times more likely to be diagnosed with depression in adulthood. So a lot of times what we see is that widespread uncertainty, especially during times of severe restriction and repeated disruptions during the pandemic, have pushed some youth, especially female individuals and adolescents, beyond their typical stress threshold. And to quote the paper, the development and widespread availability of timely and evidence-based global mental health prevention and intervention efforts to address childhood mental illness are critical and urgently needed. No surprises there. I think that it's been interesting to think a bit about what the impact of social media and access to constant information has had on all of us, and including our young people. I've been interested in the last few months to learn a bit about work that Jonathan Haidt, who is a social psychologist, has done. And he recently wrote this article in The Atlantic titled "End the Phone-Based Childhood Now?" The environment in which kids grow up today is hostile to human development. And he notes in his work, as we have highlighted already, that the rates of adolescent depression and anxiety seem to be stable in the 2000s, but they rose by greater than 50% from 2010 to 2019. We know that there's been increases in the suicide rates as well in our age group, and particularly for girls, and that these findings are been fairly universal. They're not unique to the United States. And he argues that a number of factors are contributing to that, and that loneliness and friendliness among American teens, friendlessness rather, American teens began to surge around 2012. At the same time, scores in reading and math started to decline, and that was reversing decades of slow but generally steady increases over time. And this happened globally and seemed to also begin in the early 2010s. Now, it's important to keep in mind that many of our young people are flourishing, but also many are shyer and more risk averse than they were considered to be as a population in the past. But in general, Gen Z, which is those who were born between 1997 and 2012, as a group would be considered to be in less well mental health, and they're lagging previous generations on a number of metrics. And of course, if this generation is doing poorly, if it's more anxious and depressed and is starting families, careers, and important companies at a substantially lower rate than previous generations, then the sociological and economic consequences are going to be profound for the entire society. So what happened in the early 2010s? Haidt, who is at New York University's Stern School of Business and is a professor of ethical leadership, highlighted in his paper these two quotes, which I wanted to share with you today. Those were the years when adolescents in rich countries traded in their flip phones for smartphones and moved much more of their social lives online, particularly onto social media platforms that are really designed for virality and addiction. And he goes on to say that once young people begin carrying the entire internet in their pockets, available to them day and night, it altered their daily experiences and developmental pathways across the board. Friendship, dating, sexuality, exercise, sleep, academics, politics, family dynamics, identity, all were affected. And life changed rapidly for younger children too, as they began to get access to their parents' smartphones and later got their own iPads, laptops, and even smartphones during elementary school. A week or two ago, I saw an 8-year-old who had his own smartphone, and I asked him why his dad wasn't able to make the visit today, and he showed me on his smartphone that he was tracking his dad driving through the highways of Chicago at that very moment. So more and more young people are attached to the internet. And so Haidt argues that there are 4 norms that we need to break in order to have to break 4 collective action traps that we have in place. And so he argues that no smartphones should be given to kids before high school, and that they should not have access to social media before age 16. He argues for phone-free schools, and I think perhaps even most importantly, more independence, free play, and responsibility for children in young ages in the real world. The challenge, I think, with the ideas that are presented there about no smartphones before high school and no social media, I'm going to give you the example, the 8-year-old that I saw in the last couple of weeks, is that in many ways, it would be incredibly challenging for families to make these kinds of decisions independently, and their children might be subjected to even more isolation because they're not part of the group, because they don't have the same access that all of their peers have. Some have argued that there may be value then in bringing together groups of families to make decisions together to try to enforce some of these changes. But I think the challenges are great at this point in time. I do think that, we can say that, since the 1980s, the children have really had far less opportunities for independent and free play, and far less responsibility, again, overall as a group. And those are opportunities that we can potentially encourage that would lead to less time available to be on one's smartphone. I also think that another contributing factor that we need to think a bit about is, why school absences have exploded almost everywhere. And this was highlighted at the end of March in the New York Times, where they really say that the pandemic changed families' lives and the culture of education, and that our relationship with school became optional. And of course, this can contribute more and more to the isolation and friendlessness that we've talked about. And you can look at these numbers here and see that it doesn't seem to make a difference as to whether someone is rich or lives in a poor school district, how long their schools were closed, what size the school district was, or what the racial makeup is of the school. The chronic absenteeism, which is defined as being absent more than 10% of the days of the school year, increased significantly between 2019 and 2023. This particular article gave us a chance to actually go boil down to individual school districts to see what kind of changes have been taking place in absenteeism. And so I was able to pull from a number of communities here in Ohio. So you can see that in Columbus, they were already at a 42% chronic absenteeism rate, and that jumped up to 58%. In Cleveland, it went from 32 to 56. And in Dayton, where I am today, went from 34 to 47%. Can you imagine what it'd be like to have more than half of your students chronically absent from school? I was curious, about how that impacted other districts that weren't those central urban districts. And I happen to live in a little town of Oakwood, Ohio, population 9,000, with one of the highest rated school districts in the state of Ohio. And you can see that at baseline, they started out at 4%, but in 2023, they were up to 12%. And you can say, well, 12% compared to these others is really not much of anything. And that's probably true. But to think that those numbers have tripled, even in a very highly functioning community with tremendous amount of resources, says something, I think, about the fact that people are starting to think differently about school and whether or not the children need to be there all the time. So, there has been a push. There's been legal legislative types of efforts to try to address social media. That's happened here in Ohio. We had a new law in Ohio that cracked down on social media use among kids. A judge blocked that enforcement of that law, limiting the use of social media in February. But this is just a highlight of an article that was in the New York Times in March 28th that responded to the fact that Florida had banned kids using social media, but highlighted that it really won't be that simple. We talked about the fact that it's complicated by the fact that there's less free play, there's highly managed schedules, there's fraying of the social fabric that leads to less in-person interaction, there's a constant stream of news that heightens anxiety. But what David French offers to us is that parents are better positioned to suppress social media smartphone access than the government really is, and highlights the fact that in 2011, the U.S. Supreme Court reaffirmed that minors are indeed entitled to First Amendment protection. So this is a complicated issue. It probably isn't going to be solved from a legislative perspective. We need to be thinking at it mostly from a cultural perspective and from a family values perspective. So with that bit of background, let's talk a bit about the most common manifestations of anxiety that we see in our preteen youth: separation anxiety disorder, generalized and social anxiety disorder. And then we're going to talk for just a couple of minutes about how we might distinguish ADHD from anxiety while recognizing that often ADHD and anxiety coexist in many children. So separation anxiety disorder in the DSM-5 has a lengthy description of the criteria that must be demonstrated, and that symptoms need to be present and cause significant distress for at least 4 weeks. I'm not going to read all of these, but I think that the important thing is that we're seeing developmentally inappropriate and excessive fear or anxiety concerning separation from those to whom the individual is attached. Now, we all are very aware that there are certain developmental stages where a bit of separation anxiety is expected and developmentally normal. That especially is true in young children, even in 9-month-olds as they develop the concept of object permanence, and then those 18 to 24-month-olds as they become more independently mobile and can indeed walk away and separate from those who are their attachment figures. And then often we see some developmentally temporary signs and symptoms of separation anxiety as kids go off to school for the first time. What we're really talking about here is kids who have sustained symptoms that cause significant distress. And that can be present really at any age. And then we have a group of kids who have much more generalized anxiety. It's not just focused on separation, but also excessive anxiety and worry that occurs more days than not for at least 6 months and concerning a number of different events. And the individual finds it difficult to control the worry. The anxiety and worry are associated with at least one of the following 6 symptoms: restlessness, feeling keyed up or on edge, being easily fatigued, having difficulty concentrating, which again raises that question about ADHD, irritability, muscle tension, and sleep disturbance. You know, I just had a conversation earlier this week with one of the families that I work with of a 17-year-old child who's experiencing some anxiety. And I asked the question, what kind of things do you worry about? And her father's response to that question was, she worries about everything, you know. And I recall a young child, maybe 10 or 12, that I talked with a number of years ago, who I asked the question, do you have any worries about your body or about your health? And the answer to that question was, oh, doctor, I worry about everything, you know. And that certainly pointed me down a path that needed to be addressed. And then third, we have social anxiety disorder, which is really a persistent fear for at least 6 months, excuse me, of one or more social or performance situations in which the person is exposed to unfamiliar people or possible scrutiny by others. And the individual fears that he or she will act in a way that will be embarrassing and humiliating. Exposure to that situation almost invariably provokes anxiety, which can make it be a situationally bound form or predispose one to panic attacks. And so the person recognizes that the fear is unreasonable or excessive, and the feared situations are avoided or else are endured with intense anxiety and distress. And so we certainly see that at times in children in the preteen age group as well. When we think about ADHD versus anxiety, I think that there are some valuable historical factors that can contribute to helping to differentiate those, but to recognize too that they may indeed coexist. In ADHD, distractibility or inattention usually occurs for no reason whatsoever, whereas in anxiety, that distractibility and inattention is because they're worrying or nervous. I often will share with families that what's happening for kids with anxiety is they're so preoccupied with the things that they're worried about that they cannot focus on the things that others expect them to be attending to at that time. So it's rather an issue of being over focused on the wrong thing as opposed to being unable to attend in general. Also, most kids with ADHD do not have any physical complaints unless they're having side effects from their stimulant medication, which also is uncommon. At the same time, kids with anxiety will frequently have somatic physical complaints, and sometimes those are the things that trigger the visit to the doctor, whether that's chest pain or headache or abdominal pain in particular. Those are the kind of things that sometimes are the initial presenting concerns that are brought to the medical professional. Kids with ADHD may have difficulty sleeping due to hyperarousal. They just can't settle themselves back down. And kids with anxiety, just like we were just talking about, will have difficulty getting to sleep because they can't get rid of their worries. And that leads to an area of focus and intervention that we'll talk about shortly. And then in ADHD, stimulants decrease the difficulties, obviously. There are some instances where stimulants will worsen anxiety or even pull out anxiety. And although it's uncommon, it definitely is seen, and it's something that I have certainly seen in a number of patients over the years. In general, ADHD tends to be seen more in boys, but I think that some of that can be countered by the fact that females will tend to have higher rates of the inattentive form of ADHD and may not get the kind of attention that they deserve because they're not as disruptive as the kids with combined type of ADHD. Whereas in anxiety, it tends to be equal in boys and girls in the younger age group, and then it seems to be more like seen in girls as they move into adolescence. So how does anxiety present in a primary care setting? We talked a bit about this already, that the first symptoms might be physical symptoms that bring a child to our attention, headaches, stomach aches, and chest pain in particular, but also restlessness, trouble relaxing or sleeping, a pounding heart or shortness of breath. I had a conversation last week with one of our cardiologists who was, asked to see a patient because of these kinds of symptoms of pounding heart, and found an entirely normal heart and no signs of any arrhythmia, but then had a difficult time getting to the point of thinking that there might be some other underlying source of anxiety that may be at play. Mental tension may be a factor, and worries, tension, bad concentration. We've talked about that constant level of arousal, being easily started or having repetitive or intrusive thoughts. If we think about whether there may be social or separation factors, they may not want to leave home, or safety or a safe person, or they might be avoiding feared objects or situations, or things that remind them of those situations. They might have be speaking only in front of certain people. We aren't going to talk today about selective mutism, but that's another variation of how children might present with anxiety. And I've certainly seen that many times in preschool age children who talk well when they're with familiar people, but then don't talk at all, say, for example, at preschool. Irritability and arguing for reasons that aren't clear, and then sometimes, especially in young children, repetitive play. I think it's always important for us to remember that if we're seeing a child who's presenting with anxiety or even any other kind of behavioral changes, that we assess the possible relationship to current or past trauma. And that could include a variety of different experiences that are outlined here and that all of us are familiar with. The key thing is, how do we pull those things out and recognize that we might not always be able to get that kind of information. But it's important to keep in mind that these kinds of experiences are unfortunately quite common for our children. And again, going back to the Ohio survey that was done in 2021 of middle school students who said that they ever saw someone get physically attacked, beaten, stabbed, or shot in their neighborhood. And you can see these numbers, and you can see the The racial and ethnic differences, which are dramatic and substantial, and you can see that as the kids get older, they're more likely to have had these kinds of experiences. This is also true if we look at middle school students who were ever bullied on school property. These numbers are astounding. And over 40% of children in middle school who have ever been bullied on school property by their own report. Much more common in females, but the numbers are very high for sixth, seventh, and eighth graders. And again, you can see the differences by race and ethnicity. Similarly, and I think, again, this goes back to the things that we've talked about in terms of social media, that the number of students who were ever electronically bullied is 30%. And again, you can see the differences between males and females, and you can see the differences between race and ethnicity. And then I think one more, students who did not go to school. Again, we talk about chronic absenteeism. Is this one factor that's at play? Because they felt unsafe at school or on their way to or from school. Again, 17% of the sixth, seventh, and eighth graders said that they had not gone to school because of the concerns about their own safety. And you can see the pattern. The patterns are very similar here as well as to what we just discussed. And so, with that in mind, I think we also have to keep in the forefront the fact that 76% of suicides in this particular study were found to be preventable. Among all specific causes of death, the highest percentage of males was found in suicide death review, 72% males. Large percentage were kids who had previously communicated suicidal thoughts to somebody. And the most common external injury cause of suicide death or asphyxiation by hanging, followed by gunshot wounds. So how do we get this information? Mostly it's not volunteered, or the extent of it might be withheld to us. Children and their families might be ashamed or don't want to reveal the cause of what's happened. They may be unable to really tell the content of dreams or anxious thoughts. So some screening questions that we might consider that could be of value to try to get folks to be open to pulling things out are listed here. Are there things that worry you so much you can't get them out of your mind? Are there things you or your child are afraid of? Are you or your child often worried? Are you or your child easily scared? One of my favorites that I often use clinically is, has anything bad, sad, or scary happened recently? And to you or to your family or to people that you care a lot about. The core symptoms that we might see related to trauma are listed here, and they include avoidance, hypervigilance, and re-experiencing. I think we're all familiar with those, but we need to keep an awareness of those. And if you get positive answers to those initial screening questions, then it's important to dig a little bit deeper and say, how much does this get in the way of you being in public or around other people or shopping or other tasks that require one-to-one interaction? Again, how much does it get in the way of you going to school or going out alone? And is it ever so bad that you start to feel physically unwell, feel your heart racing, or feel short of breath, or break out into a sweat? Questionnaires can be helpful, but they're not always the perfect tool that we would like them to be. Tools like the pediatric symptom checklist and the strength and difficulties questionnaires don't cover anxiety in a tremendous amount of depth. They do tap into it at a very superficial level, but could potentially miss anxiety in some kids. So there are certainly tools that are out there designed specifically to help us tap into whether or not children are experiencing a significant amount of anxiety. The Screen for Childhood Anxiety Related Disorders is one of those. It's available in the public domain. This particular example is taken from the AAP's ADHD toolkit, but it has a parent and child version, and it helps differentiate generalized anxiety from separation anxiety and social anxiety, as well as helping us to see if there's significant school avoidance. And it can be used as early as 4 years of age. There's also readily publicly available a child and adolescent trauma screen that really helps us to get a more in-depth look at what trauma kids may have experienced over time, and that is available through the National Child Traumatic Stress Network. And then we can also, if we really have significant concerns about trauma, we can also screen for post-traumatic stress disorder. The child trauma screening questionnaires that again are available through the National Child Traumatic Stress Network have 10 questions here that help us to get an idea of whether PTSD is something that really needs to be considered and that referral for support is indicated. If 5 answers are yes, then that's worrisome. And the challenge that I think we have is that our middle school students generally do not feel that they get the kind of help that they need. You can see here that really only 20 to 25% of students really feel like they're getting the help that they need. And so that in the pediatric environment, we have an opportunity to begin to provide support and intervention in a setting in which many children have grown up and are comfortable and can make hopefully appropriate referrals for support in the community if they're indicated, and to help to raise this number past its 20 to 25%. So one approach that we can take is to really just think about how we approach our interactions with youth who might be struggling with their emotional well-being in general. And this mnemonic developed by Larry Wisso, who's boarded in pediatrics as well as child and adult psychiatry and is currently at the University of Washington, helps to give us a framework for thinking about how we can facilitate a positive interaction that leads to a sense of hope, while we also demonstrate our own empathy by listening attentively and acknowledging the struggles and sharing happiness experienced by the child and family. The L is for 2 words, language and loyalty, that we want to use the family's own language to reflect our understanding of the problem as they perceive it and give them an opportunity to correct any misperceptions that we might have. And then to communicate loyalty to the family by expressing our support and commitment to help now and in the future. And then P, there's 3 Ps: permission, partnership, and plan. Taking the time to just ask a simple question about, well, do we have the family's permission to ask for more in-depth and potentially sensitive questions, or to suggest further evaluation or management when our initial screening process identifies the need to really consider taking a deeper dive. And then expressing the fact that we will partner with the family to help to break down any barriers or resistance to addressing the problem. And then we'll work together to establish a plan. And it might be a first step plan to help the family move forward and to plan for follow-up and further assessment and treatment. So help, hope, empathy, language, loyalty, permission, partnership, and plan. Just one example here of a way that we could support our families that are coping with anxiety is this tool that was developed a number of years ago by Dr. Lisa Zimnick, who at the time was in pediatric primary care practice and is now part of our team of acute care services here at Dayton Children's, to really help you think about an action plan similar to what you might have with an asthma action plan. And so that it helps to provide opportunities to think about how to prevent, and then how to handle things when they just might be starting to get started, and then how to deal with a panic attack. We're going to also include in the follow-up, there's another example of a tool that you can use with very similar step-by-step approach that you can take that's available, will be available to you in the follow-up communication after today's presentation. And keep in mind too that all of us really, I think, are experts in really being able to offer guidance and support on things that we know can help to break stress. Whether that be emphasizing the importance of quality sleep, balanced nutrition, and healthy physical activity, getting outside in nature, emphasizing the importance of supportive relationships, and maybe dabbling in helping folks to think about what mindful practices they might institute, and then when appropriate, linking families with mental health care. And these are things that we think of all the time in terms of general health promotion and prevention that are of particular value for those who might be suffering with some emotional distress. So a number of practice-based interventions to consider. I think one of the most important is educating the patient and family about anxiety and what it is and normalizing it to some extent, but reassuring the patient that some anxiety is a good thing. Small amounts of anxiety stop us from doing dangerous things or from getting in trouble at school. It can help motivate us to study so we do better in school. It's not a good thing when it makes our bodies feel badly and when it stops us from doing things we want to do or need to do. And sort of putting it into that context of normalization, but also when it gets to a certain level, then we need to be doing something different about it. Bibliotherapy, or giving folks resources that they can read or read with their child or have their child read, is important. These are just two examples of many resources that are out there. You'll find your favorites, and you'll want to share those potential resources with the children and families. Again, going back to the things that we already know make a big difference. Routines lead to fewer surprises and less stress for everyone. If we can write them out and be consistent in following them, they can make a big difference in helping to reduce anxiety in our youth. Good sleep habits are vital and make a huge difference in helping to address overall wellness. And the same goes for nutrition and exercise. And so these are things that we already know and that we need to just reinforce when we're seeing kids who are suffering from anxiety. There are some specific techniques that we might want to think about developing some mastery of to be able to share and teach to our patients who are suffering from anxiety, including the whole idea of stopping automatic negative thoughts. One way to do that is to think about putting your automatic negative thoughts into an egg and forgetting about them. There are a number of techniques that have been proposed in a resource here with this link to help us to learn a bit more about things like mind reading and fortune telling, always or never thinking, and guilt beatings, and how we can get rid of those. So those are potential resources. I think, a lot of these kids have trouble being able to get to sleep at nighttime. And one simple tool that they can use to help to get those anxious preoccupations to go away at bedtime is to start to use a worry box where they keep a pad of paper and pencil in a box near their bed. And at bedtime, they either talk about their worry with someone they love or write it down and then put them in the box where they can't bother the child, and then move the box into a safe place that's outside the room so that those are gone and no longer something that they have to perseverate on as they settle down to go to sleep. There are lots of other tools that are readily available to all of us for managing stress, and I won't talk in depth about all of them, but things like bubbles and Play-Doh and textured cloths and sunglasses and music and movies or comic books can all be tools that can help some kids. And oftentimes the kids will tell us what seems to help them, and then we can reinforce them using those on a more regular basis to help them to manage their symptoms of stress and include them in that action plan that we talked about a few minutes ago. There's good evidence that using exposure to tackle fears is an effective method for addressing anxiety, whether that be social anxiety or specific fears that individuals have. And oftentimes this can be best addressed in the context of a relationship with a trained mental health professional. But keeping in mind that if we're in a position where we're helping families to know what kind of strategies can be helpful in addressing anxiety, and we're linking folks with mental health professionals, then the idea of working on exposure to tackle fears is something that we should endorse and encourage. And there are a number of ways that that can be done. And this just gives some steps in sort of thinking about what exposure to tackle fears could look like. We can also, expect that kids could benefit from learning to use guided imagery and progressive muscle relaxation. And we hope that our mental health professionals can really help to teach kids that, but there may be times where we may decide that we want to become versed in being able to teach our own patients how to do some of these simple kinds of interventions that can be highly effective in addressing anxiety. And then, we know that cognitive behavioral therapy is a hallmark of effective treatment for anxiety. And we should be able to talk about it with families to help them to be able to know what to expect and find that it's goal-oriented and problem-focused, and that it requires active participation, and there may be homework to do, and help the children to really identify and respond to those dysfunctional thoughts they're having, and then use a variety of techniques like we've just been talking about to help change their thinking and mood and behavior. Now, finally, I think medication is an important piece of the puzzle, and the best data that we have would suggest that combination treatment with medication and counseling is preferred for most cases and can lead to an 80% response rate. Selective serotonin reuptake inhibitors or cognitive behavioral therapy alone may only lead to a 55 to 60% response. The placebo response is less than 25%, so you can see that the treatment does make a difference. The selective serotonin reuptake inhibitors are the first-line treatment, and the FDA has approved sertraline, fluoxetine, and fluvoxamine for use in children based on studies that were primarily done in obsessive compulsive disorder. I always remind families that it takes 4 to 6 weeks to see the benefits, and the dose may likely need to be adjusted over time in order to be effective. We always talk about starting low and going slow and finding the lowest dose that will do the job with minimal effects of the potential side effects of headache or gastric distress, and sometimes insomnia, sometimes sleepiness too. And so sometimes they give the SSRIs in the evening instead of in the morning. I want to just highlight that duloxetine, whose brand name is Cymbalta, is the only FDA-approved medication for anxiety, but it hasn't been found to be as effective as the SSRIs. And so it is approved for generalized anxiety in children aged 7 to 17 years old, and the recommended dosage schedule is listed there to start with 30 milligrams once a day for 2 weeks, and then potentially going up to 60 milligrams, which is really the maximum dose that's generally recommended for pediatric age group. So this just highlights what we just talked about. Fluoxetine and sertraline tend to be my first line choices, and paroxetine is not approved for use under 18, and it's important to keep that in mind. It is the one drug that was more associated with self-injurious thinking than any of the other SSRIs when the black box warning was placed. I often find that families because anxiety runs in families, that there will be a family history of a certain medication that's been a good fit. And since the cytochrome P450 system is the metabolic pathway for these medications, the genetics and pharmacogenetics of that can be helpful. And so a family history can be a good, quick, cheap pharmacogenetic test that can help inform decision-making with regard to choice of medication. And then this just outlines that notion of starting low and going slow and what the maximum dose would be for the various medications. And so there, I think I have a few references for your future study if you choose to do so. And I think we have about 10 minutes left for questions or comments if folks would like to engage. So thanks very much for joining me today and for your attention, and welcome any comments or questions.
Thank you, Dr. Doobie. Yes, we have time for questions, so you're welcome to use the chat box if you'd like to put any questions in the chat box, or even at this time, if you want to unmute and ask your question, you can do that as well. I'll just say on my end, while we're kind of waiting for questions to appear, I'll be sending an email out tomorrow with information about applying for CME credit. And as Dr. Doobie mentioned, some of those handouts and some of our resources from the Ohio AAP on anxiety as well. So look for that coming tomorrow.
I think I'll stop sharing if that makes sense. You can either enter a question in the chat. Thanks for the affirmation, Brianna. I appreciate that. If there's other questions that folks have, I'd be glad to consider them. If not, shall we wrap it up?
Yeah, if there are no questions, we just want to say a huge thank you to Dr. Doobie from the Ohio AAP for, again, another wonderful session. I'll be posting this on the Ohio AAP's preventative health webpage if you're interested in using the video again. And then again, I'll be sending out information about applying for CME credit and resources from the Ohio AAP on this topic, as well as others from our preventative health series. If you have any questions about the program, feel free to reach out to me. My email is included, and I'll be emailing you tomorrow as well. Otherwise, I hope you all have a great weekend, and hopefully we'll see you at one of our webinars in the future. Thank you.
Thank you, John.
Thank you. Have a great rest of the day.
All right. Thanks, Mark.
Thanks. See you later.